Okay, so a patient comes into the emergency department. They're known to have an opioid use disorder. They may have recently used illicit fentanyl. They're profoundly sedated. We think they might be opioid toxic. Naloxone is administered, more naloxone is administered, and they don't necessarily wake up as we would expect. However, within 2 to 4 to 6 hours, they suddenly become more and more tachycardic, more and more hypertensive. They start to get agitated. They start to get delirious. They start vomiting. We think they're in opioid withdrawal. So we start to administer full agonist opioids to treat the withdrawal. They're becoming more and more tremulous. So we think they're in benzodiazepine withdrawal. So we start to administer benzodiazepines. Maybe we do a CWA protocol. And now they're becoming even more agitated and delirious than they were before. They deteriorate to the point where we can no longer manage them with the tools we have on the ward or in the emergency department, and they're transferred to the ICU where they're administered dexmedetomidine, Precedex, and they settle. So this is a common scenario that we're starting to see more and more across North America, including here in British Columbia. What this is, it's actually medetomidine withdrawal. So let's talk about what is medetomidine. Medetomidine is now more and more common adulterant to illicit fentanyl. What it is an alpha-2 agonist. Not the first time we've seen an alpha-2 agonist. Xylazine was an adulterant that was quite prevalent 1 or 2 years ago. And now we're seeing medetomidine, which is about 100 times more potent than xylazine. Both medetomidine and xylazine are veterinary medications used for sedation of animals. Now we have a human medication, dexmedetomidine, that we use in the ICU for sedation purposes as well. Well, let's talk about what medetomidine withdrawal looks like. It's essentially the case that I outlined. We have tachycardia, increased heart rate, hypertension, increased blood pressure, tremors, but really it looks like more like shivers. Like imagine a patient that's extremely cold and they're shaking, as opposed to coarse tremors that we see in benzodiazepine withdrawal. It's actually quite distinct. Confusion, agitation, and delirium, as well as nausea and vomiting, and the vomiting can be quite profound and refractory to antiemetics. This can progress to the point where they need to be transferred to the ICU to receive dexmedetomidine for management. So how is medetomidine withdrawal treated? Well, it's typically treated by replacing the alpha-2 agonists. Now, the medication we have for that is clonidine. That's the one that we're able to typically use on the wards. When clonidine is not adequate and the patient deteriorates further, then they're transferred to the intensive care unit to receive dexmedetomidine, which is about 100 times more powerful than clonidine. So what we've done in our lab is we've developed a pharmacologically derived withdrawal protocol utilizing clonidine. This is a symptom-triggered withdrawal protocol, very similar to CWA that we use for benzodiazepine or alcohol withdrawal. So it comes with a scoring scale, because what we essentially needed to do is to develop a way to score medetomidine withdrawal in order to be able to have the actual withdrawal guide the treatment. So we developed a medetomidine withdrawal severity scale, which includes heart rate, blood pressure, delirium, agitation, nausea, vomiting, and shivers or tremors. And based on the score of the scale, a dose of clonidine would be triggered. We have criteria to escalate the treatment to beyond clonidine, which would be dexmedetomidine. We have a criteria to de-escalate the treatment and ultimately for it to be discontinued based on the patient's withdrawal score. This is something that currently doesn't exist, so we hope that it'll be an important tool to treating our patients, particularly given that our colleagues from the Northeast, particularly UPenn, tell us that about 25% of their ICU beds are now occupied with medetomidine withdrawal. Our hope is to initiate treatment much more quickly in order to prevent deterioration of our patients and the need to transfer them to the ICU. The link to this protocol will be down below in the description. description of this video. It can also be found on our website. We did do a more detailed video with one of the foremost experts in medetomidine, which is Dr. Jean Marie Perron from UPenn, and the link to that video will also be below in the description. So that's a quick video on medetomidine withdrawal, our new withdrawal protocol, and please feel free to reach out to us if you have any questions or comments. Thank you.